Our next speaker is Professor Banu Arun. Professor Banu Arun is a professor of breast medical oncology from MD Anderson Cancer Center. Also, she is a coordinator of clinical cancer genetics, and she will give us a talk about new classification and updated treatment options for triple-negative breast cancer. Professor Arun.
Thank you very much. I would like to thank the organizers for inviting me again. It's a great pleasure to be here. If I can go back to the beginning of my slides. Okay, here we are. I made my job easy today because I have only 20 minutes, as I have presented triple-negative breast cancer and management during the previous meeting. I thought I will just not repeat what I had discussed last year, but build on it. There's some new data in regards to especially the neoadjuvant treatment of triple-negative breast cancer. Very recent results presented at the San Antonio Breast Cancer Conference, so I thought I will mostly focus on that because for some it might have treatment and change in clinical care indications. So very, very short background, as I promised. Triple-negative breast cancer is about 15% of all breast cancers. Based on some epidemiologic studies, we know, at least in the US, there's a higher incidence in African American and young Hispanic women. Though we don't know the etiologic risk factors, we know that individuals with deleterious BRCA1 and 2 mutations are at higher risk. And some studies also indicate that in African American women, for example, who do not breastfeed, have a higher incidence of, if they develop breast cancer, that it's triple negative. We know that triple negative breast cancer actually responds well to standard therapy. We see some high PCR rates, but that does not translate into improved overall and disease-free survival. We also know that it tends to have an earlier relapse the first 2-3 years. And as actually Dr. Abraham just showed, on a slide, it has multiple subgroups, so it's a very heterogeneous disease. And so far, we don't have any targeted agent available, except perhaps for individuals with BRCA germline mutations, where Parp inhibitors seem to work very well, even as single agent, with response rates going up to 40%. The clinical questions for triple-negative breast cancer include in the metastatic neoadjuvant and adjuvant setting, are there any specific type of chemotherapy? Are there any chemotherapeutic agents that work better than the others? The other area or topic include individuals with deleterious germline mutations or triple-negative breast cancer where individuals don't have a germline mutation, but the tumor characteristics are similar. We call them BRCA-ness. And also, I think we still are going back and forth in terms of role of anti-angiogenic agents, and I'll give you some very updated data in regards to anti-angiogenic therapy, especially in BRCA mutation carriers, and also what are the targets in subsets of triple-negative breast cancer. As I mentioned at the beginning, because I went through this last year in much detail, I will not go through known data, how triple-negative breast cancer patients, what the results are when we treat them with standard anthracyclines, taxanes, capecitabine, eribulin, but I'll just focus on ixabepilone because the data I'm going to present is very recent. And that's the Tnt study that I had not discussed last year that was presented by Denise Yardley, looking in the adjuvant setting at doxorubicin and cyclophosphamide, followed by either paclitaxel given weekly or ixabepilone given every 3 weeks for 4 cycles, and patients were stratified by lymph node status. And the primary endpoint was disease-free survival in the intent to treat population. I will be skipping a lot of details of the study, but the primary endpoint, as I mentioned, was disease-free survival, and there was no difference when patients received ixabepilone versus paclitaxel in triple-negative breast cancer. And the overall survival curves are also very identical. So the other area I mentioned I will discuss is triple-negative disease in BRCA positive patients, the ones with germline mutations, or what we call sporadic, and here I define it without germline mutations, but where the tumor might resemble the features that individuals with germline mutations have. Again, we call them BRCA-ness. And again, because we know from studies and research that these tumors, though patients don't have any germline BRCA mutations, the tumors have actually defective DNA repair, either caused by methylation-induced silencing of BRCA or mutations in other genes that are involved in DNA repair. But what that means for us in clinical practice is that even in BRCA-negative patients, there's an opportunity to look at DNA-damaging agents such as the platinums and DNA repair inhibitors such as Parp inhibitors. And one important aspect is also that will come up when we talk about the future trials in triple-negative breast cancer is that BRCA-ness is associated also with tumor-infiltrating lymphocytes and somehow improved response to neoadjuvant chemotherapy if treated with these agents very preliminarily. And that's, again, an opportunity for immune checkpoint regulators in triple-negative breast cancer with or without mutations. So I want to now go into the platinums, the Parp inhibitors, and I'll talk a little bit about angiogenesis inhibitors. In terms of triple-negative breast cancer and platinums in stage 4, I had reviewed this extensively last year, so I'm not going to go into details, but just as a refresher, just in one slide, that based on phase 2, randomized phase 2 or phase 3 studies, the addition of platinums to standard regimens improves response rate significantly. The range is anywhere from 1 to 30, even higher percentages, depending on the line of treatment. So for metastatic treatment, obviously, the platinums have a role in triple-negative breast cancer. We really don't know the exact line, whether first or second line, but it's an option. An update that I had not presented last year is the Tnt study that is a phase 3 study that compared docetaxel to carboplatinum in metastatic triple-negative breast cancer with or without BRCA germline mutations. In this study, as you will remember, the objective response rate was not different amongst two arms. So whether patients were treated with carboplatinum or docetaxel, the response rate was not different, which I think was a surprise because we thought that perhaps the carboplatin arm would have a higher response rate. The progression-free survival was also not different, and the overall survival was not different as well. But when the investigators looked at objective response rate by germline BRCA status, as you can see, there was a significant difference. So individuals with BRCA mutations when received carboplatinum had a 68% response rate versus only 33% for individuals who received docetaxel. And one important endpoint was also whether the HRD assay score could actually predict in especially non-germline mutation carriers, because we need some type of tool to select out patients who would respond better than the others. But unfortunately, based on the HRD score, there was no response difference amongst the high score and the low scores. So now let's move to the area of neoadjuvant studies with the platinums, where we have some very recent updated study results presented a month ago at the San Antonio Breast Symposium. So there are several single-arm phase 2 or randomized phase 2 or randomized phase 3 studies looking at the platinums in the neoadjuvant setting in triple-negative breast cancer. The red highlighted ones do show a benefit when the platinums are added to standard neoadjuvant chemotherapy, mostly containing anthracyclines and the taxanes. And I will expand a little bit on the GEPAR-6 and the CLGB 40603 study. So just as a refresher, the CLGB study, as you recall, is a neoadjuvant study in triple-negative breast cancer looking at a taxane followed by anthracyclines, and then 3 more arms plus bevacizumab or plus carboplatinum or plus the combination of carboplatinum and bevacizumab. And again, you will recall that especially when we look at PCR rates in the breast and axilla, when carboplatinum was added, the response rate increased from 41 to 54%, and when bevacizumab was added, the PCR rate increased from 44 to 52%, which was statistically significant. However, when the study was presented, I remember amongst our group we discussed, well, we don't have the disease-free results, so we will not adopt it right away, but we'll wait for the disease-free survival analysis, and that will really help us. So I will show you whether this really helped us or not. So these are the very recent updates as of a month ago, reporting on the disease-free survival of the study. So this first slide basically shows the event-free survival in patients, regardless of treatment, who achieved a PCR versus patients who did not achieve a PCR. And in line with previous studies, including the ones from our institution, we know that when patients achieve a PCR, their outcome is better, and this is demonstrated in this study. They also reported on the overall survival, and again, if you achieve a PCR in breast and axilla, you do better than patients who don't achieve a PCR, and that was statistically significant. Now, very important and important for us in clinical decision-making, when they looked at event-free survival by use of carboplatin, yes or no, there was no difference. They also looked at overall survival for carboplatin versus no use, and again, there was no difference. They did the same analyses for bevacizumab, and as you can see here again, in terms of event-free survival, there was no difference, and there was also no difference for overall survival. So before I go into the implications of this, I want to just very briefly summarize the other study that was presented, and then make some comments and editorials. The second study that was updated was the Quinto study that also gave us some survival analyses. As you will recall, this study is a little bit different in that everybody received bevacizumab and then plus paclitaxel and non-pegylated liposomal doxorubicin, and the study arm received carboplatinum, but it was weekly treatment. So the difference from the other CLGB study is that the carbo was weekly, and both arms received bevacizumab. When we look at the PCR rates, and I also want to mention that the triple negative analysis is a subgroup analysis because the whole study population also included HER2 positive patients. But nevertheless, you can see here that with the addition of carboplatinum, the response rate increased from 37, the PCR rate increased from 37% to 53%. That was significant. And now, interestingly, and here it gets a little bit confusing for us who want to really make sense out of studies, when they analyzed by BRCA status, having a BRCA mutation, germline mutation, actually, though number-wise the PCR rate was higher, that was not statistically significant. So again, based on the Tnt study, you would expect that patients with carboplatinum in the neoadjuvant setting would have had a higher PCR, but the study didn't show it. And then, as I mentioned, the presentation was aimed to give update on disease-free survival. And unlike the previous study, the CLGB study, the effect of carboplatin in terms of disease-free survival was effective. So patients who received carboplatinum had a longer disease-free survival compared to patients who did not receive it with a significant p-value. So I think that this slide basically summarizes at least a number of people's thought leaders and my thought, as well as our group discussion we had at our institution. So we all agree that I think achieving a PCR with any treatment, in this case with the platinums and bevacizumab improves disease-free survival and overall survival. So PCR is a good predictor for outcome, but it appears more on a patient level. So if you achieve a PCR, no matter with what, you will do better compared to patients who don't achieve a PCR. So the addition of either carboplatin or bevacizumab to neoadjuvant chemotherapy did not improve disease-free and overall survival in CALGB, but did in GEPAR-6 though. And there was a very nice discussant who kind of tried to explain the differences. And it's possible that the study population was different, the backbone of the control arms were different. In the, as I mentioned, GEPAR-6 study, everybody received bevacizumab, carbo was given weekly, and there were also, I didn't show those details, but more lower risk patients in the GEPAR-6 study. So the population might have been a little bit different. And it's very hard, obviously, to compare two different studies. But it could be that dose and schedule of carboplatin could be evaluated in other definitive studies, perhaps in more biologically defined subsets, for example, the just, pure germline BRCA mutation carriers. And indeed, there are some studies going on now looking at the platinum, cisplatin, or carboplatinum in the neoadjuvant setting in BRCA mutation carriers, the INFORM study, for example. And also, I think one important aspect is that these neoadjuvant studies are powered to show differences in PCR rates, but they're not in event-free survival endpoints. So the suggestion is that when we do neoadjuvant studies, maybe power them so that we can actually evaluate event-free survivals as well. And there are some studies now going on looking at those. And also, importantly, I think is everything is a benefit and risk side effect balance. So we, for example, and I would love to hear from you all, when we give our patients anthracyclines and then carbo with paclitaxel, for example, we have a number of patients who cannot complete their planned treatments because of the toxicities, whereas when we give our patients the same regimen, ACT, for example, without the carboplatin, almost everyone is able to complete their planned chemotherapy. So it is possible that what I do, for example, with carboplatin, maybe save it for patients, younger patients, really high risk, stage 3 patients, maybe mutation carriers, but again, looking at the GEPAR-6 study, mutation carriers actually did not benefit. So right now, I think the studies are not very straightforward, and it's still we still make our decisions based on clinical circumstances. And very briefly, anti-angiogenic drugs added to chemotherapy. Several preclinical studies, this is just one example, showed that in triple-negative breast cancer, VEGF expression is higher, and also VEGF-related gene signatures are also more expressed in basal subgroups. I will not go in detail through this, but when bevacizumab is added to chemotherapy in randomized trials, we do see that the response rate significantly is improved, but we also know that this is not translated into disease-free and overall survival benefit. In the neoadjuvant setting, I will go over the GEPAR-Quinto update in a minute. We did not see major improvement, and in the adjuvant studies, definitely no disease-free survival was documented. So I want to update give an update on the GEPAR-Quinto study that was also just a month ago reported at San Antonio. As you will recall, this is a study where the addition of bevacizumab was evaluated in the neoadjuvant setting to anthracyclines and taxanes. Here, again, sub-analyses in only triple-negative breast cancer patients did show that actually the PCR rate improved from 28% to about 40%. That was statistically significant. Disease-free and overall survival in all of the patients, including the HER2 negatives, not in the triple-negative subgroup only, but in the whole study population, was not different. They updated the results looking at BRCA. And again, interestingly, mutation carriers had a little bit better benefit. Their PCR increased from 38% to 66% with the addition of bevacizumab to anthracyclines and taxanes. But so far, based on their report, this did not translate into improved outcome in mutation carriers. So the practical conclusions for bevacizumab in triple-negative breast cancer, I can say that in the metastatic setting, it increases response rate when added to chemotherapy, but without impact on disease-free and overall survival. In the neoadjuvant setting, we see that PCR is increased, but again, the impact on disease-free and overall survival is not very clear. It appears that in the BRCA positive group, the PCR rate is higher, but so far has not translated into disease-free survival improvement. And in the adjuvant setting, as I mentioned, there's no impact on disease-free and overall survival. Very briefly about Parp inhibitors, I had shown this last year. These are the summaries of the initial studies, basically showing that most probably for breast cancer, the highest response rate we see in BRCA mutation carriers, and in some studies where non-mutation carriers were included in triple negative, the response rate was either not seen or very low. And unlike in ovarian cancer, in breast cancer, again, having a tumor that is BRCA-like is not enough to respond to Parp inhibitors, whereas in ovarian cancer it is. If you can give me just 2 minutes, you can take it away from my next tomorrow's talk. So in terms of targeted, thank you. I'm stressing out here looking at the seconds. In terms of triple-negative breast cancer, as I mentioned, it's a very heterogeneous disease. Dr. Ibrahim had shown this slide with multiple subsets, and I think this gives us the opportunity to understand the carcinogenesis in these subtypes and then identify the targets and plan targeted therapies. I think one important and very in area is now immune checkpoints, and several studies are actually going on, are planned, phase 1, phase 2, not single agent, but combination studies with PD-L1 and PD inhibitors, especially in BRCA mutation carriers, but also triple negatives. And other targets for triple negative breast cancer, I think the list is growing every time I do a literature search. Many of these are either based on preclinical studies I've put here, or there are some phase 1 studies going on, and then planned phase 2. So I had mentioned the DNA repair pathways with Parp inhibitors, of course, VEGFR inhibitors, sunitinib. There are new angiogenesis inhibitors that are being tested, EndoTech-1, for example. And even the SRC pathway has been now looked at in triple-negative breast cancer. And as you know, dasatinib inhibits the SRC pathway. So some studies with that is being planned. mTOR inhibitors are being tested, targeting trail with lexatumumab, TGF-beta, CDK7, and some very novel agents, for example, selective glucocorticoid receptor modulators are being tested in phase 1 studies. So there's a lot going on, and I'm sure that next year, if I get invited, we will have some results of these studies targeting the subtypes. So in conclusion, triple-negative breast cancer, as we all know, is a very heterogeneous disease. For stage 4, chemotherapy is still mainstay. I think the platinums and other agents, eribulin, taxanes, anthracyclines, do work in these patients. In the neoadjuvant setting, the platinums, I think it's still a question mark despite some of the disease-free improvement results. We still don't know what subgroup benefits most in triple-negative breast cancer from the platinums, and we always have to take the toxicity into consideration. And I think the best way to approach it would be, as suggested, doing neoadjuvant chemotherapy trials with not only PCR but event-free survival endpoint, and perhaps doing the studies in subgroups and not using the gemisch of all triple-negative breast cancers, maybe the AR positives or the BRCA positives or the immune-related ones. And then including into these studies additional markers such as the HRD assay scores, tumor-infiltrating lymphocytes, and others. And I know that there are many studies going on with serial biopsies looking at these biomarkers. Thank you very much, and also thank you for the additional time.